So let's move on to look at the peak flow rate as part of our asthma patient review. So once the patient's been diagnosed with asthma, we can use a peak flow monitoring to assess response to treatment. It may be that we start them on an inhaled steroid and we want to get them back after a couple of months to see has lung function improved after that. Pretty much the same way that we get people with diabetes back for a follow-up HbA1c to see if the drugs are working. We also possibly can use it to start to help patients identify trigger factors. This is especially true in work-related asthma. You know, it may be that we give them a peak flow meter if they tell us that they're absolutely fine at the weekends, they're fine in the evenings, but there's something at work that's kicking them off. It may be that we can use it to help put our finger on what that is. And last but not least, we may want to establish a baseline for the construction of a management plan. So what is this peak expiratory flow rate test then? It's a really simple test of lung function. It measures in litres the maximum speed that a patient can blow out when they start from a full inhalation. Now, just have a look up on this scale here. What you're looking at here is litres per minute. So it goes down to 60 and it goes up to 800. And when they talk about litres per minute, this is how many litres, if your patient was to blow full on for a full minute, how many litres of air would be coming out of their body, if you like. So that's what it's measuring. So it's in litres and it's speed. If your airways are obstructed, the air can't flow quickly. So the slower the speed at which the air flows through your airways, the more obstructed the airway is. So that's basically how it works. I touched on this earlier when we very first started this module, when we did the basic structure and function. It primarily tells us how fast air is moving through these big airways, the large airways. It isn't very good at telling us what's going on down here at the bottom. The other thing about peak flow readings is that they are subject to individual variation, and what a predicted peak flow is would be based upon age, gender, ethnic origin and stature as well. And that's where we get our tables of normal values. So this is just an example for you. A lot of the GP computer systems have got little apps buried within it that extract this data automatically. So when you come to do an asthma review, it'll tell you what the predicted is. But just to kind of give you a bit of background to that, the app will extract, it'll say, right, how old is this person? What gender are they? What was the last height that was recorded? And with all of that, it'll calculate a predicted peak flow. So it'll predict what, let me give you an example here. So let's pretend we've got a 50-year-old lady who is 160 centimetres in height. If that was buried within your patient computerized records, the app would have extracted that plus their ethnicity as well, and it would then just use that as the predicted. But on a chart, the way we would do it, we would say, right, okay, that up to there, and we'd say, so the predicted is about 410 litres per minute. So that's how we discover what's normal for one person and what's, different for somebody else. The thing about peak flow is we've got to make sure that the patient performs the test properly, and accurate readings are dependent on patient effort and also muscular strength. So when you're asking a patient to perform peak flow, you need maximum effort. They've got to blow really fast from the very beginning. Otherwise, you can't really trust the test result. So I'm going to do a very quick step-by-step guide to recording peak flow in such a way as to maximize the accuracy of those results. First bit is all about assembly of equipment. Make sure if you're doing this within a surgery, if your patient can bring their own meter in, that's fabulous, but it does need to be in good working order and it needs to be less than a year old. Make sure that you're using, if you're using it for multi-patient use within the surgery, make sure that you use an antibacterial filter here, one of these. Ask your patient to stand up or sit down, whichever position they normally adopt to perform the test. It's best to ask them to do that. Ideal world, it's better if they're standing. We should advise them not to flex the neck. Then they should push the gauge right down to 0. And be careful that when they do start to blow out, the fingers don't impede this. We then ask them to take a big, deep breath in. After they've taken the deep breath in, they're asked to immediately place their lips around the mouthpiece. And they should not hold that breath in for longer than 2 seconds. Okay, so it's a big, no more than 2 seconds, and then blow straight out again. They then blow out into the meter, and it's a sharp huff, as forcefully as possible. So remember, no slow, gentle breath out. This has got to be full on. And often the word that we use is a huff. Ask them to pretend that they're blowing out candles on a cake. Take a note of the reading, put the needle back down to 0 again, and patient has a moment's rest, and then you repeat it again twice over. I'll show you how to test for accuracy in a second. Just a little bit of additional patient education and advice for you. Ideally, they should use the same peak flow meter each time. Sometimes within families, if you've got a couple of different people with asthma, they will swap and share equipment. That should be discouraged. The next bit to all of this is that we get them to record their peak flow every day, twice a day, to get a useful pattern of scores. It's always a good idea to get them to do this a few weeks before they come in for their annual review or the follow-up review. Again, we advise patients to record the peak flow at the same time of day. So get them to record it on the sheet and then join up the dots. Now then, with regards to time of day, in the morning, that it should be done as soon as they wake up. So ideally, they would have the peak flow meter on their bedside locker, and the minute they wake up, they do the recording before they've got a chance to have inhalers or have a cigarette or whatever else that it is that they do first thing in the morning. And they need to use their best effort each time. Just to go back to this, sorry, with the evening, it's not at bedtime. You want it to be done early evening, maybe 6 to 7 o'clock, not at bedtime. And that is how we would get them to keep a peak flow diary. I'll show you later when they come for their annual review and they present you with this, how you interpret this data. Okay, so a few rules and regulations. Ideally, there should be less than 20 litres per minute difference between all 3 readings. If you get more than 40 litres a minute difference, well, we then have got to do 2 additional ones because you can't guarantee accuracy at that point. And then what you do after that is you document the highest of the 3 acceptable readings. So let me show you how this would work. So let's pretend that our first patient, first reading 340, 350, 345. Well, find your first one and then find the lowest one. And there's only 10 litres a minute difference between that. So we can say that definitely sits within the 20 litres per minute, and that'd get a thumbs up and we could use that data. Let's look at a bit of a different one. If you look at 380 and the closest one to that is 340, well, that's already 40 litres difference. And it's even more with that, so you'd have to reject that one. Do another one. 525 is the top one, 480 is the bottom one, and clearly that is a thumbs down. Another one, start with the highest, 270, look at the lowest, 255, that's 15 mils difference. We can do that. And last but not least, find the highest one, 185, find the lowest, 175, and we say, yep, that is 10 litres a minute, we can go for that. What you would then do is, on the ones where you've got 3 accurate readings, you go and choose the highest one, and that's the one that you would record in the records. So for that one, it would be this, and then for that. If you get more than 40 litres a minute, well then what the guidelines recommend is that you get your patient to do 2 additional blows. So if we take the readings from the previous slide, eventually we did get 3 readings within 20 mils of each other. And you do exactly the same thing. You go, right, well, we'll have that one. Same thing again. And you choose the highest one again. Okay. Now then, you've got your readings. Let's pretend now that your patient's come into the surgery and part of your review is I've got to check the peak flow. So it's okay recording it and saying, oh, this is 290 litres per minute. But is that good or bad? We need to know what it is as a percentage of the predicted. There's another one that we use, it's the percentage best, and I'll show you that in a second. So this is our pretend patient, and we've done all of the bits and pieces on here, and the chart said it predicted that she should have a peak flow of 410 litres per minute. Okay, so let's have a see what she blew. So she should have blown 410. She actually blew 300 litres per minute. We now need to know what is that as a percentage of predicted, because this will start to tell us how obstructed these airways are. And so what we do at this point, we get our calculator out, and that's the equation that we use. We look at the actual, we then divide it by the predicted, we times it by 100, and that is the number that we want. So 300 is the actual, we divide it by what it was predicted to be, 410, times it by 100, and it ends up being at 73% of the predicted. So if we interpreted this, we would say it's 73%, it's less than the lower limit of normal, and therefore it needs investigating. So if you were doing an asthma review on a patient and this is what you got, you would have to refer this on to the nurse clinician or to the GP, because you know this would be like getting a blood pressure of 160 over 100 this. So this would need referring on. Now then, some people in asthma have got a better, best peak flow than they're predicted. I'm going to show you about that now. It's nothing different. It's not much different to calculating this. So sometimes their best peak flow is better than what the charts predicted. Have a think about blood pressure. If you had a patient and their blood pressure was 100 over 60 and it's been that from them being 16, and it's been that all through the life, it's never gone up, that's their best, that they've got really good, lovely low blood pressure. If that person turned up to you and you did an assessment on them and the blood pressure came at 140/90, you would say that's fabulous, that it's within normal limits. However, for that person sat in front of you, their systolic blood pressure has gone up by 40 and the diastolic blood pressure has gone up by 30. So even though it might be within normal limits for the mass of the population, it might be telling us a story about that person sat looking at you. So if there's a situation where you know that that patient's personal best is better than the predicted, well then going forward you've got to compare all future results with what you know is that patient's best. So let me use our patient as an example. So let's suppose that our patient here previously recorded a personal best of 450. Okay, so what we now know is that she is capable of achieving better than what was predicted. So at this point, when she then blows a current actual one, which is 300, we've got to then recalculate because this might be a signal that her asthma is actually worse than previously thought. So you do exactly the same equation, it's just that you use personal best rather than predicted. And at this point, we've discovered that actually a percent predicted is now lower than previously calculated. So personal best versus predicted, let's show you this bit. So if we look at that, if we compare the current one with what we know she's capable of, it comes up to 67%. If we compare it to the predicted, it's 73. And so therefore, we may very well be underestimating the severity of an actual peak flow if we use a predicted when our patient's capable of better. Okay, I hope that makes sense. So what I have been kind of chatting about on the last couple of slides is what happens when a patient arrives at their annual review and we do a one-off peak flow. In reality, the best way to use a peak flow is via a peak flow diary. A one-off peak flow in a GP surgery, it just tells us what's going on at that tiny moment in time. And that might not be a true reflection of how bad or how good our patient's asthma control is. So it's always best to compare your patient's current peak flow to what's happened in the past. Never view it as a one-off. And do you know what? We never do that in diabetes, do we? You know, if you were doing a diabetic review and you sat there and you saw an HbA1c of 70, we wouldn't just record that, would we, in a set of notes? We'd be going, right, 70. Right, well, it's not good. What was it last year? Because if last year it was 108, actually, even though it's not to target, we're quite pleased with that. If last year it was 54, we're kind of not chuffed with that. You know, it's the same result, but actually, when we compare it to how it's been previously, it affects the way that we interpret it. And that's how it should always be with asthma as well. So never interpret it as a one-off. So we're now kind of getting into what I think is the best use of a peak flow machine in asthma. And it's to do with this thing that's called the diurnal variation, or lung function changes that occur between day and night, if you like. Now, all of us, even if you've not got asthma, it doesn't matter, but all of us, our airways will show a difference between morning and night. Okay, so in the middle of the night, what often happens is your airways tighten up a tiny little bit. And the purpose of that is to stop us accidentally inhaling something that is potentially harmful to us in the middle of the night, you see. So it's a normal, natural, physiological action of our bodies. All of that will happen to us tonight. It's perfectly normal. However, in people with asthma, it's exaggerated. So it's made much worse. But the only way that we could know about that is we know if we went round and started doing the lung function at 3 o'clock in the morning, and obviously that is never ever going to happen. So what we do is we ask our patient to record the peak flow every morning and every night for a minimum of a couple of weeks. And what we want to assess is what is the difference, because the bigger the difference, the worse the asthma control is. So ideal world, You would get your patient to record their morning and night peak flows for a minimum of 2 weeks. And when we get this data, it's our job then. Your patient does this, they do it at home. With a bit of luck, they follow all the rules and regulations that you've taught them that we saw a little bit earlier. And then they come in for their annual asthma review. And it's our job now to interpret that. Now, the other thing about all of this is there isn't anything stopping you getting your patient to do this at home and then take a picture of that and send it in. You know, earlier I was saying to you about asthma control test is fabulous. However, sometimes you can miss uncontrolled patients because it doesn't correlate very well with lung function. Well, you know, if you think about it, if you're going to get your patient to do one of these diaries, they're doing them at home anyway. If that patient can't get in, or for cross-infection reasons you don't want them to come in, there's nothing stopping you being sent images of this. Our job though is to know how to properly interpret it, and that's what I'm going to show you how to do now. So this is when you wish you'd listened in CSE maths, let me tell you. Maths is not my strong point, by the way. So my son thinks it's a miracle that I can actually even use a spirometer or even calculate these. And to be honest, I totally agree with him. However, there is a simple mathematical calculation that even I can do with a calculator. So if I can do it, I know that you can do it. So what you do is your patient comes in or they send you this via an image, it don't matter. What you've got to do now is you've got to have a look at this pattern. And what you do is you've got to find the highest average peak flow. And I've chosen this, and the average is 340 litres per minute. The next thing you do is you need to find the lowest one. And I've gone for that one. So that is 220. And as you can see, the equation that we've got to use on our calculator is you find the highest and you take away the lowest from the highest. You then divide whatever that result is. You divide it by the highest peak flow. So 340 take away 220 is 120. You then divide it by the highest peak flow, which is 340. You times it by 100, that gives you the percentage. So the difference in this morning and night is 35%. So you now know, you've now interpreted that, you've calculated it. You want to know, is that acceptable? What is that telling you about this patient's asthma? Well, let me show you something here. If your patient has got a difference between morning and night of more than 10%, that is regarded as being excessive. So therefore, if you've got a patient and the difference is 35%, that is really, really excessive. And that would support a diagnosis of poorly controlled asthma. So that is how you calculate the diurnal variation. To me, this is the most accurate use. A one-off peak flow at an annual review, to be honest, I'd never trust that on its own. I always think about the one-off peak flow a little bit like, you know, like using a glucometer in a diabetic review. Imagine that. Imagine you're doing an annual diabetes review. Your patient comes in, you get your little finger prick test out, and you go, come on now, let me check your sugar. And you look at it and you go, look at that, it's 7 today, that's marvellous. We'd never ever in a million years do that, because we know that that test is nowhere near as accurate as an HbA1c. The other thing we know is that that test just tells us about what's happening at that moment in time. It doesn't give us a bigger picture. So for me, in asthma, a one-off peak flow is a bit like a BM stick, whereas a diary over a few weeks is more like an HbA1c. The thing as well that I'm going to tell you about this now is this, your patient has got to do this accurately, and you've got to get that message across. So when you ask a patient to do one of these diaries, you've got to back it up and say, listen, I'm asking you to do this because I need a bigger picture of how well controlled your asthma is. Now then, if you give me inaccurate data, I'm going to make an inaccurate assessment of how bad your asthma is, and that might make me making decisions that are not in your best interest. The reason I'm telling you this is there's been lots of pieces of work done into this. In fact, in one piece of work that made me kind of giggle a bit was they put a secret microchip in peak flows, and they asked patients to record the peak flow. And of course, what they discovered when they got the microchip out was that the patients had obviously not done it, and they just filled it in at the last minute. And it made me giggle because, I don't think we need to do a piece of research to find that out. But from our perspective, you can only interpret what you're being given. You have to be certain that it's accurate data. Would you take a fasting sugar off a patient who came in and said, "Oh, I'm sorry I'm late, I called in Starbucks for a muffin"? You'd say, "Well, I'm sorry, but I can't take it." If you were handed a urine sample for, say, albumin and creatinine, and the patient said, "Oh, I've just dropped it off, I've just been doing my 5-mile morning run, I'll just go and do my sample," you'd reject that. And equally, we have to reject any data that might not be accurate in asthma. Okay, so let's just tidy all of this up and let's have a look at how you might use one of those diaries in a follow-up review. So I have a pretend patient here, and the pretend patient has got a predicted peak flow of 233. That's their predicted. So week 1, they get started on treatment, and after the end of week 1, they come along and they go, "Right, here we go. I started my treatment here. This is me week of peak flow recordings for you to interpret." So the first thing that you do, you identify the highest and the lowest, because you need that in order to calculate the diurnal variation. But the other thing you need to look at is the baseline, because it's predicted is 233. So that predicted, if you ever think about it, that's 220. So you'd want, that's the predicted line. So straight away you can see that the baseline is less than the predicted. So that's something for you to kind of keep your eyes open for. So the next bit is you've got to kind of comment on it. And what I'd be saying here is the diurnal variation is 28.5. Well, we know that that's bad now because it's way beyond 10%. And I'd say that the peak flow baseline is less than predicted. So that's how I'd interpret that. Let's pretend we got them back after 2 weeks, and straight away when you sit these next to each other, straight away can't you see that that's getting better? So you now know that the baseline is increasing. So we think, right, we're on the right tracks here. And you choose your highest and your lowest. And we discovered that this week the diurnal variation is 20%. Now we know that's still bigger than what it should be, but nevertheless it's 8.5% less than what it was the week before. So we're heading in the right direction here. And my comment to this was, well, that peak flow is slowly but surely starting to increase, and that diurnal variation is slowly but surely starting to decrease, and this is what you're after this. But let's pretend now we say, right, I'm going to follow you up in 3 months, see what happens. And straight away, when you look at this, you know that the baseline's got better. It's significantly higher than what it was 3 months ago when we started. So straight away, you know that we're doing a good job. Still calculate this. We now look at that and we go, look at that, it's 11.5. And what we would be saying is that peak flow is now greater than predicted. And even though the diurnal variation is still slightly higher than what we wanted, it's almost halved since we last saw this patient. And we'd be really happy with that if we saw that. And what I'd be saying to this patient is, can I see you now again in 3 more months? And can you bring me in a couple of weeks worth of this in 3 months? And what I'd be expecting in 3 months is for this to have dropped less than 10%. So I hope that that's been useful. And I will see you in the next video, where we're going to start to apply all of this theory now into a patient assessment.